to another insightful episode of The White Side of the Brain. Today, we are honored to have Professor Fanny Mochel with us, a leading expert in the field of neurometabolic diseases and leukodystrophy. Professor Mochel is a professor of genetics at La Sorbonne University, and she heads two French reference centers on neurometabolic diseases and leukodystrophy in the Department of Medical Genetics at La Pitié-Salpêtrière Hospital, as well as a research team on immunity, metabolism, and neurodegeneration at the Paris Brain Institute, called ICM, together with Violeta Zjujovic. So thank you very much for being here, Professor Fanny Mochel. Let's get started. So you were a little bit late today because you were saving a life in the subway. So thank you anyway for being here. You are a doctor, so that's why you're helping people daily. First question, and very simple question. What is white matter?
So usually the way we like to explain it is pretty much taking the example of a cable for just electricity conduction. So you have the cable itself that allows for that conduction, which is usually the neuron with the axon as a prolongation. And then you have something around it that is going to protect that axon, that cable. And this protection is not only very important to protect from damages or anything, but it also helps to facilitate the conduction and to make it faster. So that surrounding of basically the cable is what we call the white matter. And anything that is going to impact this white matter, this cable, like holes, it can be some holes from genetic origin because of some genetic disease affecting the cells that take care of this surrounding, this sheet, what we call the myelin sheet. Or it can be some acquired diseases like multiple sclerosis, which is really the most common one. Any holes in this sheet is going to slow down the conduction, basically. And so usually the consequences are very different, but going to be cognitive or motor or psychiatric problems. So anything affecting basically the well-being of the brain.
So thank you for this comparison. It makes it very clear. So you're specialist of ALD, adrenoleukodystrophy. Can you tell us a little bit more about this disease, please?
So it's actually a complex one to explain, not only because it's, of course, a rare disease and the mechanism actually are complicated because it involves biochemistry, it involves a lot of cascade of events, but it is also complicated in the form of which the disease can present. And also it can affect children and adults, and in adults it can affect men and women, so with different kind of presentation. So to summarize, the beginning of the problem is the mutation in the gene that is located on what we call the X chromosome. So the X chromosome makes X and Y, men and women, different because men have only one copy of it and women have two. So this is why we consider that the most severe form of the disease usually affect the boys and the men with this condition. We call it X-linked disorder. But what happens actually is that mutation in the gene called ABCD1 is going to impact the import of some lipids. We call them the very long chain fatty acids. Some lipids into a special compartment from the cell, which is called the peroxisome. And this is some kind of metabolic unit that pre-process those lipids in order then to transfer them to the mitochondria where the energy is produced. So when you have a mutation in the ABCD1 gene, and especially when you're a boy or a man and you don't have another copy to deal with this, your transporter for the very long chain fatty acids, those lipids, is going to be impacted, and therefore they don't enter properly into this peroxisome, this metabolic unit. And there are different consequences, but to summarize, we could say that one of them is an energy problem because whatever is transferred to the mitochondria is deficient. So there is a problem in the energy production from those lipids. And the other thing for which we are starting to understand is probably some important immune dysfunction. So the cells that are involved in regulating immunity. And this is probably explained because actually the metabolism of those lipids is having an important role in the switch that those immune cells are having between something which is sort of inflammatory or something which is instead regenerative. So In our body, we have immune cells not only in our blood, but also actually in our brain. And for some of them, they have the same source. And those cells actually are very dynamic, so they can switch from a state to another of inflammation or regeneration. So initially, when there is an attack, they are going to be inflammatory, but then they switch. And those switches are driven by metabolic changes, including those lipids. So when you have a problem in this lipid pathway, basically your immune cells are more prone to be inflammatory. And so this is one of the components we see. So in summary, there is a mitochondrial energy problem and an inflammatory immune problem in this disease. Now, the clinical presentation, again, as I said, is complex because we sort of summarize it by three main phenotypes. One, which is the involvement of the adrenal gland. So this is unrelated to the brain. It's really what allows to synthesize the cortisol in particular. So patients have adrenal insufficiency. The second phenotype is what we call the adrenomyeloneuropathy. So it's really more about the myelopathy, which is a disease that is going to cause some spastic gait, so some spasticity, some stiffness basically in the legs, which is going to impact years by years the ability to walk, and for some patients it can lead them to a wheelchair. It can be associated with a neuropathy, so it's what then leads to some what we call neuropathic pain. And the third presentation is this leukodystrophy that we call the cerebral form of the disease, which is a sudden inflammation of the brain, which is usually associated with loss of cognitive abilities or motor abilities or even psychiatric symptoms. So these are the three main, the adrenal insufficiency, the myelopathy, and the cerebral form. And they are not going to affect patients in the same way. So for the children, only boys are affected with this disease, and they have usually adrenal insufficiency, and they may, in 1/3 of them, develop this cerebral form. So they don't have the myelopathy, and again, for children, we only follow closely the boys. But it usually can start from 2 years of age to any age, basically, during childhood and adolescence. For the adults, the men can have the three phenotypes, so the adrenal insufficiency, which is also common and may have started when they were kids. The myelopathy only develop in adults, so we don't see that in the children. And for men, usually it's between 20 to 40 years of age that the disease can start, but we have patients who have started when they are in their 60s, so to have this spastic gait. And then there is this cerebral form of the disease, which initially was thought to occur only in children. So adults were not monitored for that. And usually when patients were older than 15 years of age, there was some kind of relief that was not going to happen. But we know that now that not only this is really wrong, but it's actually probably more than half of the adult men who will develop this cerebral inflammation. So it's a lot of patients. And the also important message is that we thought that because it's an adult onset, it will be less severe. But there are important data nowadays showing that the median survival, so it means that on an overall population of children with cerebral ALD, half of them will be dead by 3 years once the disease has started. So that's the median survival is of 3 years. But we know now that it is exactly 3 years, same for the adults as well. So it is also as devastating. Now, when talking about the women, because we don't talk enough about the symptoms that they may have, they don't present as in children or adolescents. That's why we don't test for them during that time. But they may develop the myelopathy, and in different forms. It's usually less severe than the men because it starts usually after 40 years of age. But we have, of course, some patients with earlier onset. And we tend to summarize it by saying that for 1/3 of the women, they tend to have something similar, so with similar severity than men, but a bit older in life. For 1/3, they will be more or less completely asymptomatic, so they can really expect to have a normal life. And the last third of this woman may have some symptoms, but much milder. And sometimes it's going to be isolated, for example, control of the bladder. We call it a neurogenic bladder, for example, so urinary problems. Or it can be some pain related to a neuropathy, for example. So that's pretty much the picture. But they don't develop the adrenal insufficiency and they don't develop the cerebral form except for very few of them, but it's less than 1%. So it's not never, but we don't monitor the woman for the adrenal problem or the cerebral ALD like we do for the men.
Okay.
So that's a summary of this complex disease affecting different ages, but also men and women differently.
Your research focused on one kind of sort of this disease?
So we actually work only on the neurological manifestations.
Okay.
And myself, since I work now I train as a pediatrician, but I know work in adult metabolic medicine. So I don't see the children, only the adults. We work both on the myelopathy as well as the cerebral form of the disease, but our recent research has been mostly on the cerebral form, the life-threatening one, with both new ways we hope to detect this inflammation at the early stage, but also new treatments which are exciting.
Okay, so in your research you use biomarkers?
Absolutely.
Yes. Could you explain the impact of biomarkers in your research and in research in general? How does it help to be more efficient, more precise?
So there are different kind of biomarkers, first of all, and for some of them it's going to be what we call some kind of diagnostic biomarkers, so something that is going to help at the early stage to detect a stage of the disease. Then we have some prognostic biomarkers, so something that is going to try to help monitor differently patients because they are more at risk of having a severe presentation, for example. And then we have therapeutic biomarkers that can help to monitor the effect of a treatment. And these different kind of diagnostic, prognostic, and therapeutic, sometimes they can be the same for a given disease, but sometimes they are very different, actually. The idea in this rare genetic diseases is that the diagnostic biomarker, usually we don't need biomarkers to diagnose the disease itself.
Yeah.
For example, adrenoleukodystrophy, adenomyeloneuropathy, the main way to diagnose is monitoring this accumulation of very long-chain fatty acids in the blood and looking for the mutation in the gene ABCD1. But where we may need still diagnostic biomarkers, actually probably the same as the prognostic ones, are to detect some form of the disease, like the cerebral form. So it's more about detecting the cerebral ALD in particular, because we know that the sooner, of course, we treat, the better. So in this particular disease, we do need this diagnostic of cerebral ALD, not of the disease itself, but of the cerebral form. We do need to find ways to know when we should worry about a patient starting this cerebral demyelination, inflammation, because the course of treatment will be different. And of course, we need, when we start very early treatment, especially because this is one of the diseases for which there will be at some point in France what we call prenatal diagnosis.
Yeah.
So the ability to detect especially the boys in the general population with this disease, in order to do a better monitoring. But for that, when we will initiate treatment, we will need to have these biomarkers, because the idea is that the clinical presentations that we have as doctors in front of our eyes, when we examine the patient, when we ask questions about symptoms, that these clinical tools are insufficient, basically. They are not sensitive enough. It's a lot about sensitivity when we talk about biomarkers. So what help can we have from some biological measures that we can do, or imaging measures in these neurological disorders that are going really to tell us more than what we can see with our eyes, because sooner and in a more sensitive way as well. So this is really the main challenge. And I should say, because I didn't say it earlier, and it's important when we talk about this disease, is that it is the most common leukodystrophy, the most common rare disease of the white matter, and that's why also it makes it important to start with this newborn screening program that have already started in the United States, in some states, and that has just started in the Netherlands as well.
Okay.
So there will be in many countries development towards this direction.
Okay, so you're using the BrainTel platform for a while now. How do those reports can help you on a day-to-day basis to follow the treatment of the patients that you're working on?
So it's not only for the treatment, actually. I think that when it comes to this ability to monitor better what happens to the white matter of this patient, this is what happens with the BrainTel platform. We actually are talking about some diagnostic biomarkers, in the sense that The idea will be to detect the cerebral form as soon as possible. It's also prognostic because depending on the slope of how the markers evolve, we know how fast the disease is developing and what kind of treatment we should offer, because they have different mode of action, but also delay to actually provide some benefit. And of course, therapeutic indeed, as you mentioned. And what we have been facing really for ALD in general, and focusing on the question of the cerebral ALD here. So the one thing is that adult men were not aware that they needed this monitoring of the brain, because they were told that if this didn't happen when they were kids, they were off the hook. So that has been a first important message to the community, and we're still doing this, and it's not just to the patient community, but it's really to all the medical community, of course more of neurologists and geneticists, because there is still incredible, I should say, because there has been a lot of communication around that now for many years, but still many, even I would say expert centers, not specifically of course in this disease, but in rare diseases or in neurological diseases, who still don't know and who still let people develop those white matter lesions without doing anything. Up until we finally see them, and it's usually late, and when we try something, it's usually of course quite less efficient, and sometimes we cannot even offer any treatment. So really the first message has been to raise this awareness. But then when we were following the patients, and of course it's also important to mention that it's hard on the patient to have this brain monitoring, because it's very stressful. They know what we are looking at, and if something starts, it's like really like clock ticking for them. And
it's not painful for the patient.
It's not painful, absolutely not. But some patients may develop some claustrophobia. Sometimes you just have it, of course, from the beginning. But from some patients, they were initially doing well with the monitoring, and at some point, this anxiety just takes all the room. So it's actually not so simple. But of course, most of them will be able to perform, and the MRI has the great advantage not to be painful, but also not to be invasive, so there is no exposition to X-rays or things like that. And that's a major advantage, of course. But really what we wanted is to be able to detect as soon as possible this change in the brain, and for that we were able to work on cohorts of patients that were followed prospectively, and we could see actually that the brain tail markers were giving us some alert 6 months to 1 year before the standard way that we just look at the MRI and we see the white matter change. The other thing is that when we look at data from a clinical trial that we did, where patients were closely monitored, we could see the same trend that we could detect probably earlier than what our eyes can do. And again, when we know how critical it is to start intervention when the MRI is changing, it makes, of course, a lot of sense to try to detect that even earlier, or at least to get ready, because sometimes we are talking, for example, I mentioned before that the innate immunity system is involved as an important mechanism. So one way to treat this cerebral form, this demyelination inflammation, is to replace the immune system, and for that we do what we call hematopoietic stem cell transplantation, or we can also call it, because that's what we do the most, bone marrow transplant. So we take the bone marrow of a donor who doesn't have that mutation, either someone from the family or someone from an international bank. Of course, the donor has to be compatible with the immune system of the patient. And then by replacing this immune system, we actually solve the problem of the abnormal activation of this inflammatory process. And if it's done at the early stage, it's not magic, because of course there is a lot of science behind it, but it looks like magic because it stops completely all of this disease progression. And if we can do that before symptoms, then patients do not even develop symptoms. So that's also a main advantage in this disease, is that you are able to detect at a stage where you are pre-symptomatic, and this is rare, and this is, for that aspect, an advantage of a genetic disease, because you know it's running in your family or you have it, so you can be monitored at a pre-symptomatic stage, which you cannot do, for example, in multiple sclerosis, because it's only when you come with symptoms that you can detect that there is something going on. So really the platform has been very helpful for us to get this early sign of inflammation, If we have them, we don't necessarily think it's happening, but we monitor closer. And if we get more evidence that this is happening, then we can start preparing for the transplant, for example, which takes some months. So it's a gain of time, which is very important. And then when we start the treatment, and this is more about experimental treatment, because the bone marrow now is a sort of a gold standard, let's say. But there are many patients who cannot be transplanted. Because when you are older than 50 years of age, the kind of transplant that we need to do actually is too toxic. Or you can be in a patient population where your ethnicity prevents you from getting a donor with the same background than you, so you don't have a good match when it comes to the immune system. Or you have some lesions who are just too threatening because they progress too fast, and for the transplant to have an effect, which is usually 6 to 9 months, because you replace the peripheral immune system, but the time to do a correction in the brain is usually those 6 months at least. So we need to go faster. So for that, there was a lot of unmet medical need. And we have new drugs now, in particular one we worked a lot with called linaglitazone, where really we were able to monitor what the treatment could do in this patient. And this has been critical with the BrainTail platform as well.
Okay, great. Thank you. Coming back to your personal motivation and journey, could you explain what's your biggest motivation in pursuing in this field, precise field?
Well, I guess for me, as I mentioned, I trained as a pediatrician initially, and it was really during internship program. So when we are still in training before being a full doctor, that I got to encounter some of these metabolic diseases and genetic metabolic diseases. And I guess it was fascinating to realize that when you understand where things start from, and not only a genetic problem, because today there are very few gene therapy programs, so correcting the gene mutation that we can actually say are proved to be efficient, but it's a lot of development, and of course it will keep improving. But in this particular field of metabolic disease, if you understand where the pathway is altered, you can bypass it, you can try to provide other substrates or the energy, frills, for example, for the cells. And when you do that, you can see amazing things, like almost miracles, actually. Children dying from a condition and then suddenly, in a few days, just being out of trouble. So as a young doctor, that is pretty fascinating to be able to reverse some life-threatening condition like that just by understanding the biochemistry, understanding what is behind this mutation. And that has been really life-changing for me, I should say, the therapeutic motivation of what we could do. And then it was a journey to move to general metabolic problems of the body to specifically brain, which is much more difficult, of course, to target because we have little access. And that's actually why all the MRI development has been so critical, and the motivation to find the more sensitive markers that can help us really to not only understand what's going on, but also to treat. And besides leukodystrophies, I've done a lot of work in a disease called Huntington disease, which is one of the 3 major neurodegenerative conditions we know of with Alzheimer's and Parkinson's disease. And thanks to metabolic imaging of the brain, we were able to find something that was associated with this neurodegenerative disease. We were able to develop a method to monitor the energy problem in the brain of this patient. And then we were able to try a treatment for a few weeks, and we saw that the correction happened on the metabolic profile of the brain. And because of that, we then did a trial that lasted for several years, where we now have the results that it actually really stabilized the progression of the patient, which is one of the few drugs for now who can do that. So it's really this fascinating odyssey of being able to treat things that seem really untreatable when we start with.
So do you have any advice for aspiring researchers, people that are willing to begin this journey?
It's to be curious.
Yeah.
I think it's the most important thing, curiosity. Definitely to learn from different fields. I mean, I'm not just talking about my own way, but going from pediatrics to adult has been really, really instrumental to understand the whole spectrum of course, human body's development and else. But also not only looking in our fields of medicine or biology, looking beyond that. It's important to, at some point, make some bridges with chemists. At the moment, we have large interest in how physical properties of the brain can actually also be modulated for treatments, not just the biology of the cell. So curiosity is definitely what I think should be encouraged, and a bit sad to see how much, especially, I don't know if it's only from the 20th century, but a lot of it happened then in terms of education, how much we over-specialized in fields of molecular biology or cellular biology, not even knowing the two components of biology. In order to be super productive, of course, it's a lot related to how productive you can be. You need at some point to know very well your domain. But it's very important to not forget that knowing the other fields, knowing the big picture is actually, this is where the creativity will come, and in the end, the
innovation
and the breakthrough, for sure. Yeah.
Okay, and I guess that collective intelligence is also a key for the advancement of research. You collaborate a lot with teams in France. Can you speak about that and elaborate a little bit about your collaboration?
Yeah, so it goes beyond France, in particular because of this rare diseases that we need to collaborate internationally. But for our metabolic imaging in particular, we work with colleagues in the United States, where it's a center in Minneapolis that actually developed the magnets initially. So they were the one who started the possibility to do MRI. And so when we wanted to look at some compound in the brain without doing any sample, just with MRI, they have been really, really instrumental to help us set up all the methods that we had here. And one thing we learned is that also, I think, to advance research, you need to have a specific question with a very well-designed study protocol. I know people are going a lot for huge cohorts and else, and we know that we learn a lot from also study population. But when you have a specific question, if you can address it with very strict standardized methods and specific patients, you actually get a lot of information. And sometimes these small studies actually are going to help you much more than the large ones, where at the end you don't know really what you're looking at. So we are, of course, interested in trying to integrate different modalities in our research, the blood markers, the brain markers, and for that we work with bioinformaticians, in particular mathematicians. But I still think that the observation that we get from single patients or from these rare diseases is actually critical to get new ideas and to be more specific, I guess. And I like the globality, but I like also the individuality of some questions that we may have. And for that, I think the rare disease field is also helping, in general, the field of medicine. And we tend to forget that, because in those rare diseases, we know where the problem starts, so we can study better some part of brain function, for example. But this mechanism also may be happening in other disorders. So some things we are going to learn in leukodystrophies may help multiple sclerosis. We know that already. What I've been developing for Huntington started with another very rare disease. So that's why I think for the young people who sometimes think, oh, this is rare, so by definition, if it's rare, I should not learn about it, because I would just never find such patient. Well, not only these disorders are usually more treatable than the common one, but by studying them, we help the field of medicine in general.
Okay. So coming back to ALD, how do you see the future of the research and the treatments looking in 10 years, for example?
So obviously the newborn screening is going to change a lot of things, because what is very sad is that today, and talking about France in particular, the first patient of a family, so the first boy who is going to have a cerebral form of the disease, or first adult, it's usually too late, because when symptoms are there, the disease is advanced, and usually we can't offer treatment. But of course, it's important for all the family members who can benefit from early detection and early treatment. So if we have a newborn screening, then all the population will benefit systematically. So this will change a lot, how we do things. But it's a big burden, as I mentioned, and for parents who will get the news that they have a kid affected with this, it's going to change their life. And for some of them, they will be more or less asymptomatic up until they become adults. So this biomarker research is going to be very important to try to help and see if, we can't do that nowadays, but is there a time where we can say, okay, you have this disease, but it is very likely that it will only develop in adults, so you can be more at peace during those years to come when your boys develop. Or the opposite, obviously. And since there will be also new treatments, especially there is a lot of genetic development. There is already a gene therapy available, not in Europe, but in the US, as an alternative to the bone marrow transplant, but only targeting the immune cells. So it's still only for this cerebral form of the disease, but there are other gene therapy developments targeting the disease overall, that hopefully for which there will be a trial in the next years. So there is definitely a lot to look for, but the more we can monitor, because it's still rare, so you can't run a trial with thousands of patients. So you need something very sensitive to know in which direction you go. The more efficient those biomarkers, the faster we will develop these therapies.
Great. So you're positive.
Yes, absolutely.
The last question will be, why does white matter matter? That's the use.
Well, as I mentioned at the very beginning of this myelin sheet that surrounds this cable, we know that actually a lot of diseases start from there. And when we even say the word neurodegeneration, we think about degeneration of neurons. But we know now that most of these neurodegenerative diseases actually start not in the neurons, but in those other cells that we call the glia. And for that you have more metabolic cells like the astrocytes, or the ones who produce the myelin called the oligodendrocytes, or those immune cells that I mentioned that we treat with the transplant that we call the microglia. Actually, these cells are probably central in most, if not all, of the neurodegenerative diseases that we know, but also psychiatric diseases. So it's this understanding better, monitoring better the white matter is going to have a major impact for the field of neurology.
Great. Who would you recommend we invite to this podcast
Next,
yeah.
well, are you looking more on people who would be more fundamentalist on the topic, or more, I guess, have a clinical perspective?
Maybe from a clinical perspective, to have something very tangible for the audience and the listeners.
Well, I believe Professor Odile Bossfluc-Tanguy, who's been leading the reference center for leukodystrophy in France for many, many years. She's a pediatrician, but actually knows of adult also presentation of this disease. She's been instrumental in identifying some of these diseases and starting all the field of treatment.
Okay.
And I think she has a very nice understanding and very nice way to explain why actually the white matter matters.
Great.
And so it will be a nice addition, I think, to your podcast series.
Okay. So thank you very much for being here. It has been very insightful, interesting. And I hope the listeners will enjoy this conversation. Thank you very much.
Thank you for having me.
Thank you.
Bye.
Thank you for listening to The White Side of the Brain. We hope today's episode shed light on the critical role of white matter in brain care and the innovations transforming care. Stay tuned for more discussions with leading experts as we continue to explore, learn, and work towards better treatments together. Until next time, let's keep pushing the boundaries of brain science.